Welcome to the Weekly Neurology Deep Dive, your source for the latest in neurology. This deep dive is for educational purposes only. It has no commercial ties. We'll provide an overview of a recent research article, but as always, we encourage you to read the full paper yourself. Today, we're diving into a study that could really impact how you treat chronic aphasia. Transcranial magnetic stimulation combined with multimodality aphasia therapy for chronic post-stroke aphasia, a randomized clinical trial published in Neurology earlier this year. This research offers some really exciting new possibilities for treating patients with chronic aphasia.
About 30% of stroke patients have aphasia, and about half of them still have problems communicating even 6 months or more after the stroke.
So a significant number of our patients are dealing with long-term communication difficulties. What's particularly interesting about this study is that it looks at using repetitive transcranial magnetic stimulation, or rTMS, as a potential new treatment. Can you explain how rTMS works, specifically the type used in this study?
rTMS uses magnetic pulses to affect brain activity. The study used 1 Hz rTMS. This type is known for its inhibitory effects. They targeted the right pars triangularis. That's the area in the right hemisphere that corresponds to Broca's area.
But why target the right side of the brain? Isn't language usually processed on the left?
That's a good question. After a stroke that affects language centers in the left hemisphere, the right hemisphere often tries to compensate. But research suggests that this activity in the right hemisphere might actually hinder language recovery in the long run.
So it's not always helpful.
By inhibiting the right pars triangularis with 1 Hz rTMS, the researchers think they can limit this interference and create a better environment for the left hemisphere to recover its language function.
Interesting. So in this study, they combined rTMS with intensive speech therapy. Can you tell us more about the multimodality aphasia therapy, or MMAT program they used?
MMA is designed to address different aspects of communication in a comprehensive way. In this study, participants received 35 hours of MMAT over just 10 days. A key feature of MMAT is its group setting. This creates a more natural environment for communication practice, and it encourages participants to interact and learn from each other.
Makes sense.
The therapy included a variety of structured activities, like requesting items, describing pictures, and participating in role-playing scenarios to practice real-life
To
conversations.
mimic real life.
Exactly.
They used a very rigorous study design to evaluate this combination therapy. Can you walk us through the design?
It was a randomized controlled trial. Participants were randomly assigned to either the real rTMS plus MMAT group or a sham stimulation plus MMAT
The
group.
control group.
Exactly. This allows researchers to see the specific effects of rTMS. They also used a double-blind design, meaning that neither the participants nor the researchers knew who was receiving real or sham rTMS.
To eliminate bias. It sounds like they took steps to ensure scientific rigor. Now let's talk about the participants. Who were they? And what were the criteria for inclusion in this study?
They enrolled 44 participants. All of them had chronic non-fluent aphasia,
Meaning?
meaning their stroke had happened at least 6 months before the study, and they specifically had difficulty producing speech rather than understanding language.
So they could understand what was said to them.
Yes, but they had trouble speaking.
Right.
The average time since the stroke was about 4 years. And importantly, all participants had had a stroke affecting the left middle cerebral artery.
A region often associated with language processing.
Yes. They also had to be able to follow 3-step commands. This ensured their difficulty with expressive language was greater than their difficulty with receptive language.
So their problem was with speaking, not with understanding.
Exactly.
Were there any exclusion criteria?
Yes, there were a few factors that could exclude someone from the study. A previous stroke involving the right frontal lobe, moderate to severe depression, other neurological or psychiatric conditions, and severe verbal apraxia,
Which is?
a condition that affects the ability to plan and sequence speech movements.
I see. It's important to have specific inclusion and exclusion criteria to make sure they're studying a well-defined group of patients and to be able to draw meaningful conclusions from the results.
Absolutely. It's also worth noting that lesion volumes and locations were comparable between the groups.
So the two groups were similar in terms of their brain damage.
Yes. This further strengthens the validity of the study by ruling out pre-existing differences that could have skewed the findings.
Good point. Now let's get to the results. Did this combination therapy actually make a difference?
Both groups, the ones receiving real rTMS and the ones receiving sham stimulation, improved on the Western Aphasia Battery Aphasia Quotient, or YBAQ.
WAAQ.
It's a standard test for measuring aphasia severity.
So the intensive speech therapy itself, was beneficial, even without rTMS.
That's right.
But I understand there were some notable differences between the groups when rTMS was added.
Yes, the group that received rTMS along with MMAT showed even greater improvements. And these improvements were statistically significant at the 15-week follow-up.
How much better did they do?
The rTMS group had an average improvement of 7.6 points on the WBAQ, while the sham group improved by an average of 3 points.
So a difference of 4.6 points.
Which is considered clinically significant. They had a significant reduction in word-finding difficulties. They were able to construct more complete and longer sentences, and they had fewer pauses in their speech.
That suggests that rTMS might be boosting the effects of the speech therapy,
Yes.
leading to these more pronounced improvements in language function. Were these improvements across the board, or were there specific areas where the rTMS group did better?
Well, both groups improved on various subtests of the WAB, including spontaneous speech, repetition, and naming and word finding. The rTMS group showed significantly greater improvement, specifically in the naming and word finding subtest.
So this combination therapy could be particularly helpful for patients who have trouble finding words,
Yes.
which is a common and frustrating symptom of aphasia.
Exactly. And it's important to note that these benefits weren't short-lived. The fact that these improvements were sustained even at the 15-week follow-up suggests a lasting impact of the combined therapy.
Very encouraging. Now, before we get too excited about these positive results, let's talk about safety. Was rTMS well tolerated? Were there any concerning side effects?
Safety is always a top priority. Fortunately, rTMS was generally well tolerated in this study. The reported side effects were mostly mild and temporary. The most common one was a mild headache after the stimulation sessions, reported by a similar number of participants in both the real rTMS and sham groups.
So the headaches might not even be due to the rTMS.
That's possible. Some participants also experienced tingling sensations, either near the stimulation site or in the right upper extremity. Again, this was reported in both groups. And importantly, there were no reports of serious adverse events, such as seizures, in either group.
Good to hear.
These findings are consistent with what we know about the safety of rTMS. It's generally considered a safe procedure when administered following established guidelines and with proper participant screening.
That's reassuring. It's helpful to know this when discussing the potential risks and benefits of rTMS with patients. This study offers what's classified as Class 3 evidence, which is good support for the combined approach. But of course, as with any research, replication and further investigation are needed.
Absolutely. This is just one study, and while the results are promising, we need to see these findings replicated in larger multi-site trials with longer follow-up periods.
To confirm these findings,
Yes.
so this research opens up exciting new possibilities for treating chronic aphasia. Let's explore those in part 2 of our deep dive.
This study gives us a lot to build on. It provides valuable insights into the potential of rTMS to improve outcomes for people with chronic aphasia.
Let's dig into some of the details of the study, starting with the outcome measures. They used the Western Aphasia Battery Aphasia Quotient, or WBAQ, as their primary outcome measure. Can you remind us why the WBAQ is relevant in this context?
The WBAQ is a widely used and well-established tool for assessing aphasia severity. It provides a comprehensive evaluation of different language functions. It allows us to track changes in a person's overall language ability. So in this study, the WBAQ served as a reliable way to measure the effectiveness of the combined rTMS and MMAT intervention.
They also used other outcome measures to look at different aspects of communication.
Yes, they took a multifaceted approach to evaluation. In addition to the WBAQ, they used a picture naming task to assess word retrieval abilities.
To see how well they could name pictures.
Right. This task included both words that were practiced during therapy and words that weren't. This gave them insights into whether the treatment effects generalized to new words. They also used the Communication Effectiveness Index, or CEEI.
The CET.
It's a patient-reported outcome measure that focuses on functional communication in daily life.
So it looks at how well people can communicate their needs and participate in conversations in real-world settings.
Exactly. They also use the scenario test, which examines the use of different communication modes, including verbal and nonverbal strategies.
So it looks at how effectively people can get their message across using different methods.
You're right. They also assessed mood using the Stroke Aphasic Depression Questionnaire, because depression is common after a stroke and can impact recovery. And they assessed quality of life using the Stroke and Aphasia Quality of Life Scale.
It sounds like they really tried to capture the whole picture of how aphasia affects a person's life. Now let's talk more about the rTMS protocol. You mentioned they use 1 Hz rTMS targeting the right pars triangularis. Why that specific approach?
They chose 1 Hz rTMS because of its ability to inhibit brain activity. The idea is to suppress the excessive activity in the right hemisphere. That might be interfering with language recovery in the left hemisphere.
So it's like trying to quiet down the right side of the brain to give the left side a chance to recover.
Exactly. They targeted the right pars triangularis because it's thought to be the counterpart of Broca's area, which is a key area for speech production in the left hemisphere. By inhibiting the right pars triangularis, they hope to shift the balance back in favor of the left hemisphere.
I see. For those who aren't familiar with rTMS, what does a typical session involve?
During an rTMS session, the person sits comfortably, and a magnetic coil is placed against their scalp over the targeted brain area. In this case, the right pars triangularis. This coil delivers brief, painless magnetic pulses that pass through the skull and into the brain, stimulating the underlying neurons. It's a non-invasive procedure, so no surgery is needed.
You mentioned they used a sham stimulation for the control group. How did they make sure the sham stimulation was convincing, but didn't actually do anything?
They used a special sham coil that looks and sounds like the real coil, but doesn't actually deliver magnetic pulses into the brain. This keeps the participants blinded because they can't tell whether they're receiving real or sham stimulation. Interestingly, when they were asked to guess, participants in both groups were pretty much split down the middle, so it seems like the blinding was successful.
So it strengthens the study's validity.
Right.
Let's move on to the intensive MMAT program. Participants received 35 hours of therapy over 10 days. That sounds really intense. Can you describe what a typical day in this program was like?
Each day started with a 20-minute rTMS or sham stimulation session. After that, participants met in small groups for 3.5 hours of intensive MMAT sessions, led by trained speech-language pathologists.
Speech therapists.
Yes. These sessions involve a variety of structured communication activities designed to target different aspects of language function.
What kinds of activities did they do in these group sessions?
They worked on requesting items by describing features, explaining uses, or demonstrating how to use them. They also did exercises to recall items from memory, describe pictures, or participate in role-playing scenarios to practice real-world conversations, like ordering food at a restaurant or asking for directions. The group setting was a key part of MMAT. It provided a supportive and interactive environment for practice and feedback. Participants also had brief home practice tasks to reinforce what they learned during the day.
A very immersive experience. Now let's go back to the results and talk about some of the secondary outcome measures. Both groups showed improvements on measures of word retrieval, functional communication, and multimodal communication. Can you tell us more about those findings?
On the word retrieval task, both groups significantly improved their ability to name pictures. This suggests that the intensive MMAT program had a positive impact on word-finding abilities. Both groups also showed significant improvements on the CE-TI, which reflects improvements in functional communication, meaning that participants felt more confident and competent in their ability to communicate in everyday situations.
So the improvements on the CETI are really meaningful because they show how the therapy translates into real-world benefits for people with aphasia.
You're right. It's not just about doing better on tests. It's about helping people communicate better in their daily lives. Both groups also showed significant improvements on the scenario test. This means they became better at using different communication modes, both verbal and nonverbal. This suggests that the MMAT program helped them become more flexible and resourceful in their communication by giving them a wider range of tools to express themselves.
Interesting. What about mood and quality of life? Did those measures improve as well?
Interestingly, mood and quality of life, which were assessed using the Stroke Aphasic Depression Questionnaire and the Stroke and Aphasia Quality of Life Scale, respectively, didn't show statistically significant improvements in either group. One possibility is that these measures might not be sensitive enough to pick up on the relatively short-term changes. That occurred within the 15-week follow-up period. It's also important to remember that both groups received intensive therapy, which could have had a positive effect on mood and quality of life, regardless of the rTMS.
So it's hard to say whether the therapy itself had an impact on mood and quality of life.
Right.
It's also worth noting that they found a difference in functional communication between the groups at baseline. The rTMS group started out with higher scores on the CETI. Did this difference persist after the therapy?
That's a good point. Despite the initial difference, the change in CEDI scores from baseline to follow-up didn't differ significantly between the groups. Both groups experienced similar improvements in functional communication. By the end of the study,
So the intensive MAP program seemed to level the playing field, leading to similar gains in functional communication for both groups.
it seems that way. The therapy itself was a powerful driver of these improvements. Let's not forget about the breakdown of the UBBQ scores into individual subtests. While both groups improved on measures of spontaneous speech, repetition, and naming and word finding, there was one finding that stood out for the rTMS group.
Their performance on the naming and word-finding subtest.
Exactly. The rTMS group showed significantly greater improvement on that specific subtest. At the 15-week follow-up, this suggests that rTMS might be particularly effective at addressing word retrieval difficulties, which is a common and often persistent challenge for people with aphasia.
It seems like rTMS is giving them a boost in their ability to access and produce words. While the results of this study are certainly encouraging, it's important to acknowledge its limitations. Can you outline some of those for us?
Every study has limitations, and this one is no exception. One key limitation is the relatively small sample size, only 44 participants. Larger multi-site trials are needed to make sure these findings apply to a wider population of patients with chronic aphasia.
So more research is needed to confirm these results.
Yes. Another limitation is the 15-week follow-up period. We need studies with longer follow-up periods to see if these benefits last over time and to determine if booster sessions are needed. The lack of a formal assessment of treatment fidelity is another limitation, meaning they didn't formally assess how consistently the MMAT program was delivered. It would be helpful for future studies to do this, to minimize variability and strengthen the study's validity. It's also important to acknowledge the limited diversity in the study population. The participants were mostly Caucasian.
So we need more research with diverse participants.
Yes, to make sure the benefits of this therapy extend to everyone who could benefit.
Despite these limitations, this study provides strong evidence to support using rTMS, combined with intensive MAT, to treat chronic aphasia. What are some key takeaways for neurologists who work with these patients?
This study emphasizes the importance of high-quality intensive speech and language therapy for people with chronic aphasia, even without rTMS. The intensive MMAT program led to significant improvements in language function. This reinforces the idea that intensive speech therapy should be a cornerstone of our treatment approach.
So intensive speech therapies is essential.
Yes.
This study also suggests that rTMS could provide an additional benefit, especially for patients who have trouble finding words.
That's right. But it's important to have a thorough discussion with patients about the potential benefits and risks of rTMS and to set realistic expectations for improvement. Shared decision-making is crucial to ensure patient-centered care.
So involving the patient in the decision-making process is key. We also need to remember that rTMS isn't a cure for aphasia. It's a tool that can enhance the effects of speech therapy and support recovery. Now let's shift gears a bit and talk about the broader scientific significance of this study. What research questions does this study raise, and where do we go from here?
This research opens up new avenues for investigation in aphasia rehabilitation. One interesting question is the optimal timing for rTMS. We know that it had a delayed benefit in this study. But would earlier intervention, perhaps during the subacute phase of recovery, lead to even better outcomes?
So doing rTMS sooner after the stroke.
Yes, that's an important area for future research.
It would be interesting to see if earlier intervention leads to faster or more significant improvements in language function.
Another question is how long the benefits of rTMS last. We need to do studies with longer follow-up periods to see if the benefits are maintained over time and to figure out if booster sessions are needed. We also need to identify individual factors or biomarkers that can predict how well someone will respond to treatment.
So we can tailor treatment to each individual.
Exactly. Neuroimaging will play a key role in this. By using techniques like fMRI, we can visualize brain activity and connectivity changes that result from rTMS and speech therapy. This could give us insights into how the brain recovers and help us identify those predictive biomarkers.
Fascinating. Let's go back to one of the most interesting findings of this study, the delayed benefit of rTMS. It didn't show up right away, but became more pronounced over time. Why do you think this delayed effect is happening?
The delayed benefit is really intriguing. It raises questions about what's going on in the brain. One hypothesis is that rTMS might be affecting neuroplasticity.
The brain's ability to reorganize itself.
Exactly. Perhaps rTMS is making the brain more receptive to the intensive speech therapy that follow.
So it's like rTMS is preparing the brain for learning.
Right. It's possible that rTMS enhances the brain's ability to form new connections and strengthen existing ones, which makes it easier to learn and consolidate new language skills during the intensive MAT program. But these neural changes probably take time to fully develop, hence the delayed improvement.
It's like planting a seed that takes time to grow.
That's a good analogy. Another hypothesis is that rTMS might be promoting the release of certain neurochemicals that are important for learning and memory. There's evidence that rTMS can influence the levels of neurotransmitters, like dopamine and glutamate, which are both crucial for synaptic plasticity. It's possible that rTMS sets off a chain of neurochemical events that enhance the brain's learning and adaptation abilities.
So it's giving the brain a chemical boost.
In a way. Another possibility is that rTMS might be suppressing activity in specific brain regions that are hindering language recovery. We talked earlier about the potential overactivity in the right hemisphere after a stroke, which might interfere with the left hemisphere's ability to regain control over language.
Right.
It's plausible that suppressing this overactivity takes time to have an effect, allowing the left hemisphere to gradually reassert control over language function and leading to those delayed improvements.
So there are several possible explanations for this delayed effect. This study reminds us that even in chronic aphasia, the brain is still capable of change and adaptation. This research opens up exciting new possibilities for aphasia rehabilitation.
I agree. We've learned a lot about the potential of rTMS and its impact on language recovery.
In Part 3, we'll conclude our deep dive by reflecting on the key takeaways and exploring some of the questions this research raises about the future of aphasia treatment. This research has really raised some interesting questions about aphasia and how we treat it. Let's wrap up this deep dive by focusing on the key takeaways for neurologists.
This study provides strong evidence that the brain, even years after a stroke, is still capable of change. This is encouraging for our patients with chronic aphasia.
It means we should never give up on them.
The study also shows the potential of new approaches like rTMS, especially when combined with intensive evidence-based speech therapy like MAT.
So it's important for us to stay up to date on these new therapies.
We need to be open to trying new techniques.
And remember that each brain is different, and recovery takes time.
Patients' persistence and individualized treatment plans are essential for helping our patients regain their ability to communicate.
This study also raises new questions that need to be investigated, like the optimal timing for rTMS and whether there are any biomarkers that can predict who will respond best to treatment.
Imagine if we could predict which patients would benefit most from rTMS. That would really change how we approach aphasia rehabilitation.
And with new advances in neuroimaging, we might be able to actually see the brain rewiring itself as it recovers.
We've talked about the potential of rTMS, but there are other brain stimulation techniques as well, like transcranial direct current stimulation, or TDCS, and neurofeedback. These techniques might also be helpful for treating aphasia.
So there's a lot of potential for future research.
This is an exciting time to be working in aphasia rehabilitation.
With continued research and innovation, we're getting closer to being able to offer our patients even more effective and personalized treatment options.
I'm optimistic about the future of aphasia treatment. I think we'll continue to make significant progress in helping people regain their voices.
We encourage you to read the full study. We'll provide a link in the show notes.
This deep dive has just been a brief overview, so be sure to check out the full research paper.
Thanks for joining us on the Weekly Neurology Deep Dive. Until next time, keep exploring, keep questioning, and keep those brains buzzing.